Hello, everyone. Welcome to Georgetown. To those of you who are Georgetown people, welcome to here. For those of you who are from the outside, we're really glad to have you with us. So today, we're really glad to have this really amazing panel to talk about this question of kind of what happens when the next pandemic hits. I'm Matt Kavanagh from the Center for Global Health Policy and Politics. And so I welcome you on behalf of our center, the Center for Global Health Science and Security, and the Georgetown Global Health Initiative. We are going to have a remarkable panel of folks. And so let me introduce them to you. And then I'm going to moderate a discussion for a little while. And then we're going to give over some space to you all to have some questions and some answers. First off, I will start with our in part person who's traveled the farthest. And so Jason Gale. Jason Gale is Bloomberg's senior editor for global health and the author of After COVID, which I made him go get so that he could show you all. He has just published this remarkable book that's really worth a read and worth looking. And you know the subtitle of the health impacts that will last for generations is kind of the motivator in part for this panel. And we're going to use that as a jumping off point. Jason is a veteran of 25 years at Bloomberg News, where he's focused on infectious disease for a long time. To my left, there's a person who I'm sure none of you know. His name is Dr. Anthony Fauci. Dr. Fauci, yes, go ahead. That's great. I first met Dr. Fauci when he was on a stage and was quite literally being heckled by one of my friends, and giving it right back in his Tony sort of like wonderful, clear, science evidenced way that actually caused them to sit down and be quiet. But what Dr. Fauci does most of the time is to be one of the country's obviously preeminent infectious disease speakers, thought leaders, and physicians in the world. Has his own amazing book out recently that all of you should take a look at and read and buy. And we're so pleased that he is here at Georgetown as a university professor. And so please welcome him. Our third speaker, you can applaud for everybody in just a second. Okay, great. Third with us, we have Nina Schwalbe, who is a senior scholar at Georgetown Center for Global Health Policy and Politics, which we're really glad about, but is also the former deputy executive secretary and managing director at Gavi, the former principal advisor and chief of health at UNICEF, and led USAID's $7 billion vaccine initiative. And so we're really thrilled to have her both join the center and be here with us today. And definitely not least, is Stephanie Psaki. Dr. Psaki is a renowned global health thinker, doer, and person in the world who I think many of us admired her work before she was in government, when she spent 20 years working in the NGO sector, leading on a number of different global health issues, before she spent time at HHS, and then at the White House as the special assistant to the president and inaugural U.S. coordinator for global health security at the White House. So please welcome them all. So how we're gonna, and a Georgetown alum. So how we're going to do this is I'm going to go ahead and ask some questions. We're going to kind of have a discussion up here. We're going to open to you. And then we will close with Professor Rebecca Katz, director of the Center for Global Health Science and Security, who also I think in this room needs absolutely no introductions. And so she's going to close us with some kind of thoughts about how we move forward. So that's our plan from here. So let me go ahead and just dive right in. So Jason, you have written this book. Tell us a little bit about kind of the key story. I think one of the things that's interesting is that you are tracing a set of stories. You've got Dr. Tedros, you've got Joanne Liu of MSF, you've got Nancy Messonnier at the CDC, you've got Kelly McCarthy, who spent 6 weeks on a ventilator. So what are the big threads as you kind of look back toward what happened in COVID that you take out of the story?
Yeah, I think that Oh, thanks. The immediate attention is on the acute emergency, but my book looks at the long tail, what happens after that. And it looks at the personal stories, the frontline health workers, the patients, the global health leaders, and it looks at the consequences, the fractured, fragile health systems, the chronic illness and long COVID, and the mistrust and the division that exists in society. So it tries to look at all of those things.
So ideally, what we're going to do in this panel is to be a bit forward looking. The question is what happens when the next pandemic hits, but I want to spend a little bit of time digging a bit into kind of some of what did happen. So a few more questions to you. So one of my favorite pieces of your book is that and I'm so bad at Italy. You have two places that you profile, Lombardy and Veneto. So tell us the story, because I think for a Washington, D.C. audience, it matters a lot. So tell us that story of why those two places, what was different about them, and what do you learn by looking at those two?
Yeah, I think there's a quite an interesting tale to be told of Lombardy. That's the northern region where Milan is located, and Veneto next door is where Venice is. And Veneto had the first documented COVID fatality in Italy, and Lombardy had the first documented infection. And the regions initially responded fairly similarly, but then quickly their responses diverged, where Lombardy focused on scaling up ICUs and hospitals. Veneto looked at broadening testing. They wanted visibility on the virus. And in doing so, they were able to better isolate infected people and to curb transmission. And the mortality benefits were really quite striking. So I think it was an early example of why having visibility on the virus through testing was really important. But obviously, it's not just testing. You need compliance. You need a willingness to be tested and having that trust in the system to identify the infected people, and then the willingness to isolate when you were infected. So I think that was an early tale that could have offered a lot of insight.
And the reason why I wanted to start there is because I think, in DC, I can't say how many times I've heard, of course, Singapore could do that, right? Of course, Australia could do that. Of course, places that are kind of landlocked. But what is so interesting is that, Italy is not the place that you think, boy, there's a top-down authoritarian society that's landlocked, or that's water surrounded, right? Instead, very much a G7 country, now sometimes yes, sometimes no, a complicated place. And yet what you're saying is that there was a model of a place that actually did kind of do the kind of testing that we would imagine. Is that right? And so tell me more about what do you take away from that?
Yeah, but we also look at South Korea, which had learned valuable lessons from their MERS outbreak several years before COVID emerged, and how it was important to have the capacity to do the testing, but then the contact tracing and isolation that went with that. And when it worked well, they could avoid mass prolonged lockdowns. So there were some really good examples of how we could do this better.
And then finally, as we kind of start kind of framing this conversation, the other story that's in your book that I think many in this room will be quite familiar with, and possibly deeply familiar with, is the Seattle flu study team. So, but tell us that story a little bit, and why you included that in the book, and what you take away from it.
Yeah, so for those who are not familiar with the Seattle flu study, this was a program that was established well before COVID-19 emerged to track influenza in the community and to know before hospitals start filling with flu patients that the epidemic was moving ahead. And so they had systems in place to collect respiratory samples from people in the community to test for flu, but they realized they could easily adapt it for SARS-CoV-2, but faced a lot of red tape in being allowed to do that. After a while, I think the researchers were just frustrated and went ahead and tested their back specimens for SARS-CoV-2, and lo and behold, they found that there were cases in the community that weren't previously identified. So it emerged as a really useful surveillance tool. And before we had wastewater surveillance, these sorts of surveillance tools were incredibly helpful.
And that's why we succeeded so strongly in the United States at responding to COVID. Maybe you should tell the rest of the story.
Yeah, well, I think we all know what happened with testing and the frustrations that occurred with that. But now we can largely avoid some of those problems with the wastewater surveillance that is now up and running, but it needs to be supported, and it also needs the response for when we do find signals. Yeah.
So I'm going to turn to Dr. Fauci. So part of what the kind of coming out of COVID-19, right, out of the story that's told in Jason's book, in your book, and others' book, is where we got things wrong. And I think we can kind of go deep into a variety of places that we got things wrong writ large in COVID. I'd love us not to spend an hour and a half doing that, because we could do that for many, many days, and it has been done. The other thing that came out of COVID and has come out of HIV recently, is coming out of TB, is the degree to which we're seeing these big jumps in science. And so I wonder if you could talk to us a bit about the science coming out of COVID-19 and where you see us being as we try to table set at this point.
Okay. Well, thank you, Matt. So if we're looking at what we can do better with, and things that we did well and things that we did not do so well, we better make sure that we don't lose the grasp of the things that we did really, really well. And the things that we did really, really well, incontrovertibly, was the science, which kind of gets lost in the somewhat muddled public health response that I think counterbalanced in a negative way the positive aspect of the science. And I'm referring to things that are now, unfortunately, in danger of not being fully supported. Because if you look at the fact that we came up with a vaccine, that the vaccine trial, believe it or not, started 6 days, the vaccine development 6 days after the publication of the genomic sequence in a public database of the spike protein. 6 days. 69 days later, we were in a phase 1 trial, and 125 days later, phase 2, 195 days later, phase 3, and 11 months later, we had a 93 to 95% effective vaccine that went into the arms of individuals in 11 months. That's the scientific approach that we had. That didn't happen by accident. That happened because of the years of investment in basic and clinical research that antedated literally by decades. And I don't want to spend too much time on it, but just for those who don't appreciate that, the mRNA technology, the original paper by Katie Carrico and Drew Weissman, was published in the journal Immunology in 2005, 15 years before. The development of the stabilized spike protein that was the business end of the mRNA platform dates back 2.5 decades for the people who were working on trying to get a structure-based vaccine design for the HIV envelope. Not fully appreciated. The people who developed the immunogen for SARS-CoV-2 vaccine were all HIV researchers, every one of them. Barney Graham, Peter Kwong, all the people from my vaccine research unit at NIAID. So from the science standpoint, Matt, when we're looking forward, we better not put aside the science. And unfortunately, where we're seeing is not only a diminution, but an inhibition of mRNA technology, which is, I mean, I cannot imagine that that's happening when you had a vaccine was one of the best vaccines that was ever developed. So that's where the science is going. The other thing, as you mentioned, is the things that will go on now that will prepare us for the next outbreak. It had to do with things like HIV, and I mentioned the two things with the spike protein and the mRNA technologies. There are things that we're working on now. If we don't get a lot of support for it, is going to hinder us for the next outbreak. And as you all know, we don't know when that's going to be. That could be next year. That could be 5 years from now. That could be 15 years from now. We don't know. So the science is very important. I'm sure we're going to get into, and I won't spend too much time with the microphone, about that is in stark contrast to the public health missteps that took place from what you mentioned multiple times in the book, the catastrophe, not only with the testing, but the refusal to believe that there are other ways of doing it besides fixing your bad test. With the South Koreans were putting out 20,000 tests per day, and we were playing around with 5 tests that didn't work. So those are the kind of things that we have to be careful doesn't happen next time.
So let me stay on the science for just a moment. And I've got 2 more questions for you on the science. One is you started to talk about mRNA, and I'm just going to follow up on this. What are we losing right now? What are you worried about that we're losing? Because I'm at least watching, as you said, this kind of push away from mRNA and a push to almost lock it up as if it is scary in a way that seems very harmful for our prospects for the future. And so talk to us about that.
No, it is. I mean, there are a number of things that are very positive about mRNA technology. The thing that is most extraordinary about it is the adaptability of the platform to literally change overnight in developing a vaccine. And when you're dealing the way we have dealt in a very stressful way, something we'd never seen before, that within the context of a single outbreak, you had multiple variants. I mean, in the middle of a flu outbreak, you won't have like 5 separate flus in the middle of a single flu outbreak. Unfortunately, we've had like a multi-year outbreak of COVID, but we started off with the original wild type strain, and then we went from alpha to beta to delta, in mid 2021, and then Omicron in November of 2021. And since 2021, we've had, dozens of variants of Omicron. So if you want to keep your vaccine up, you cannot have a vaccine platform that is anything less than being able to clip out the spike protein sequence, stick it in the mRNA, and literally within a matter of a month or 2, you could have another vaccine. If there ever was a platform that was ready-made for an emerging pathogen that you did not know before, it was the mRNA technology. It isn't the only one. I'm not saying it's the only thing that can be used, but I got to tell you, it saved us. With all of the issues that people have based on disinformation, which I'm sure we'll get to, regarding the mRNA vaccine, if we didn't have the mRNA vaccine within 11 months of the recognition of the outbreak, could you imagine how many more people would have died who were not vaccinated? Of course, vaccination, as we know, it may not necessarily prevent you from getting initially infected, but it certainly can help you prevent getting hospitalized and dying.
So as we think about the future, as we think about future outbreaks, do we have the science that we need at this point? I have heard this out of the mouths of very important people. We have the science we need to defeat the next outbreak. We're just not using it. Do you think that's true? And I don't have a good answer to this. So this is my question.
Well,
not a leading question.
I'm glad you use that terminology. Science is a process. So we have the process. The idea is, are you going to utilize it and invest in it? From what we're seeing, what's going on at NIH, it's a bit scary. Instead of having, 400 NOFOs, we had like 17. So that's really not not something that is encouraging. So the people who can do the science are there. We need the support for the science. And that's the thing that we hopefully will not diminish in our preparation for the next outbreak.
I want to move us then toward one big theme that I hope we can touch on, which is access. So we had remarkable science, and I will add to editorialize as the moderator that not only was the mRNA technology really remarkable in what it was able to do, but you saw, a company that shall not be named. I'm happy to name it. Hire Lonza, another company, right? And go from having produced hundreds of doses at a time of vaccines to producing billions of doses of vaccines, because it turns out that this platform was remarkable, right? Able to be built up and replicated without having to actually kind of do this massive start from scratch. And so in many ways, we ended up with a set of technology that seemed like it was ready-made for distributing to the world to make sure that we could make it at scale, that we could really accomplish that. But we didn't really do that. And so I wonder about, Dr. Fauci, where you kind of see, from having sat there in the science space, but also, of course, sitting across the policy space, why didn't we make further progress on kind of sharing the technology with the world? What got in our way? And if you could kick that off, and then I'm going to come to some of the other panelists.
I don't mean to be sarcastic, but we got in our own way of that. I mean, we didn't make equity our driving force, which the arrangements you're going to be talking about, I think, soon are going to address that. But we did what we in the developed world have done continually for forever, is worry about ourselves primarily, and then worry about ourselves secondarily, and then tertiary, maybe worry about other people. So you're absolutely right. There's no excuse for people getting their second and third boost when millions of people never got their first shot. And that is, in a world in which we stand for as physicians, healthcare providers, and public health people, that equity is a fundamental core principle of public health, and that wasn't being implemented. So we were standing in our own way.
Dr. Nina Schwalbe. Sorry, we just have the one microphone. So you got, oh no, you have them too. Okay, good. So you were pulled into the US government, right? And led the USAID vaccination effort. It did not achieve equity. It did achieve some important things. As you look back on that now, what do you think we learned from that process? And I'll hasten to add that we're sitting in Washington at a moment where technically USAID legally still exists, but of course the agency as it existed does not even exist at this point. So part of what I want to come to is, what do we do about that situation? But first, kind of starting with, what did you learn from having done that?
Thank you, Matt. And just reading Jason's book is really wonderful. What he's done in the beginning of his book is he's really documented what happened in a way that allows, if you were part of the response, you can read those first chapters and reflect back and ask yourself questions. So it's really a wonderful read, as well as lots of science I didn't know before. But when I came into this position, which was as a special government employee, and now everybody knows what that is. But I came from a sense of urgency. I was in New York City when the pandemic hit. My father was one of the first victims of COVID-19. He got COVID in March 2020, and the system in New York City completely fell apart. And, I'm a doctor epidemiologist. I'm not a medical doctor. But the way that it played out in New York is I took care of him by myself. We couldn't get any palliative care, any oxygen. We had no services. So it was just me and my dad in his apartment on Lexington Avenue as he died. And it showed me all the failures in our system here in the US, the failure of lack of coordination between the federal, state, and city government, everything from how we were reporting data. I mean, I got called by the coroner and said, "What did your dad die of?" And I was like, last time I checked, I don't have this qualification to be able to call cause of death. So it got me engaged and gave us an urgency. And then fast forward to the vaccine availability, we saw pretty quickly in December of 2020 that we had a vaccine, but we didn't have a plan. And in New York City, New York State, our governor rolled out implementation really quickly of the vaccine and dropped those age limits before older, vulnerable people got vaccinated. So we did a study that was published by the New York Academy of Medicine, which said that if we'd done a better job of rolling out a limited resource technology to the people that needed it first, more lives would have been saved. So roll into USAID. Mr. President Biden made this incredible donation of 500 million vaccines, which he then doubled to 1 billion vaccines. And I think we realized that that plan was still not in place for the rest of the world. It took us a couple of months to get the vaccine out. I sort of joke that I got to USAID and I was like, okay, we got the vaccines. Where are the syringes? And people were like, syringes? So we didn't have the plan in place. And that's kind of what I want to focus on in terms of the forward-looking part of this, is we can do so much better a job of planning. And that planning goes as much to the social sciences as it does to the quote unquote hard sciences. And we sort of ignored that part of the process. And we hadn't thought about all the things that were affecting people about this pandemic. So when we started to roll out the vaccine at USAID, especially in populations that had not seen the pandemic in the same way that they'd seen it in Italy or we'd seen it here in the US, people were like, wait a second, and it's things that we've seen in HIV and TB as well. Wait a second, my primary concern here is my nutrition or my child's nutrition or my child's vaccination. So the first real lesson I think of is planning. The second lesson that I learned from that, or that we learned from that, was around collaboration. And we can't do it alone. We need to work together. So bringing in COVAX, for better or for worse, for all its pluses and minuses, but working together with everyone else was critical to that. And so that really, particularly in today's America First doctrine, makes me think, you just can't do public health that way. And the third was, I think we saw the benefits of funding public health systems, in that we saw how underfunded public health systems in crisis were just ready to crack. And Jason also covers that beautifully in his book. So this concept that, we can't just leave public health as the unseen thing that only people complain about when it's not working, but we have to invest in it. So we saw in the US here, all of the local public health departments that had lost their local epidemiologists. The system was already really hurting here and around the world. We have an underfunded WHO. We have an even more underfunded WHO now, but all these systems. So I think the real lesson to me was you can't wait till the last minute, and preparedness isn't just about the science. It's also about the systems that roll out.
Let me push you just a little bit before we move on to say, as you were trying to then navigate this promise that had been made by the Biden administration, I think, many of us, and I'll speak for myself only, right? We're like, an administration has come in that's going to achieve equity because you've got good people there, really lovely, wonderful people, including the three of you, right? Who were very, very dedicated to this as a concept. This was not HIV, where we had the head of USAID early on saying, sorry, Africans can't tell time. We can't get our HIV treatment to people. This was a set of folks who really were dedicated to that. So and I'm going to come to the rest of you, but what did you see that got in the way of doing something more aggressive, more bold, that might have achieved greater equity worldwide? Because of course, what we ended up with was, as Dr. Fauci was saying, a competition, right? And of course, that was what we knew was coming. When countries are faced with existential crisis, they think of themselves. So what were the things that got in the way of trying to do more, better, something that might have achieved equity?
Are you asking specifically about the U.S. government response or more broadly?
I am. But you can say whatever you'd like.
No, I can't believe I'm going to say this right now.
Nina, I get to push Nina because
I know, because, yeah. I mean, there was a lot of complacency, and that's where I felt this urgency coming from New York. I mean, we were 45,000 people in my city lost their lives. It was serious. We had these refrigerator trucks outside on the streets. We had sirens wailing constantly, and I knew 6 people that died of COVID. So I came in with this incredible urgency, and one of my friends talked about like during COVID, the people who were in apartments versus the people that had backyards. And I think about that a lot. And we were in apartments in a city that was a different city. And so I felt that there was a complacency still with people not seeing that devastation. And I really, I mean, we got out 300 million vaccines by December 31st. That was our goal. But I felt every day we had to push people around this, oh, you know, people need I mean, and then that goes back to what people need first or most. You know, but there was a complacency of the bureaucracy not to push forward fast enough. And I found that extremely disappointing.
Let me come to you, Dr. Psaki, who I will not put on the spot quite the same way, but in a different way.
I wasn't involved in those early days, so it's not.
No, exactly. This is why the panel of people are really special, because these are not people who had complacency. I know that for a fact because I talked to all of you during COVID. The question that I've got to come to you for is kind of linked to this, right? Which is we are kind of in this moment of having had a crisis where one of the chief things we could have done was to share technology worldwide. Right. And that obviously did not happen in the way in which it could have happened. There was a variety of reasons for that. But one of the things that's happening right now, right, is that we are in the middle of like the next stage of negotiating a pandemic treaty. Right. And I think there was a lot of applause and excitement when the pandemic treaty passed, and it had a lot of good things in it. But of course, it held this very, very little tiny thing, which is, will technology be shared in the next pandemic? What does the PABS system look like? And what kind of data is going to be shared, right? And I think, you know, many of us kind of saw from the beginning that the fundamental question was the sharing of technology by the North, the sharing of information by the South. That was what everybody had leverage over, right? And so that was the point of negotiation. And it seems like we're kind of stuck. So can you talk a little bit about kind of, you know, what is that, where do you think we are? Is there a way to get unstuck? And do you have reflections on the time, I know that you were deeply involved in this, that you were involved, about kind of what we learn from kind of where we go now?
Yeah. Well, first I'll say that it struck me reading the book, and then Nina, hearing from you. I was also in New York in the beginning of the pandemic. I had a very different type of difficult experience, which is that I had an 18-month-old and a 4-year-old, and my husband and I were both trying to work full-time, living in a high-rise apartment building where we could see the refrigerator trucks and people lined up around the block in Brooklyn. And that the trauma of those early days and weeks in New York, it was never like that in the DC area. And we felt that when we moved down here, that many of the people who lived here, thankfully, did not have that experience. But it did inform, I think, the way that we approached, you know, personally as a family, the rest of the COVID experience. So I, as you alluded to, part of my job when I was on the National Security Council staff was to oversee the U.S. negotiating position in the pandemic treaty. And so, you know, to take a step back, which I think we're getting to, but the delay in accessing COVID vaccines during the COVID pandemic has done such deep damage to the relationships between the United States and other high-income countries and low and middle-income countries, but countries in the Africa region in particular. So we can and should talk about the reasons that happened, how to fix it. But the truth is that the damage that did to our alliances is long lasting. And, you know, I think it's being reinforced by the positions of this administration. But the damage was deep, and it's very, very difficult to rebuild trust after that kind of betrayal of trust, I think, is the way that it is seen and was experienced by many countries. So when the negotiations for the pandemic treaty were launched, it was very much in direct response to that experience. So there are a lot of other topics that are included in it, but that is the core question and the core experience of how do we come to an agreement that ensures equitable distribution of medical countermeasures in the next pandemic. That is the core challenge of these negotiations. I gave, certainly sweat and tears, probably some blood to these negotiations when I was in the US government. I am deeply committed to seeing it come to a resolution. I hope the PADS agreement in May. And it is not going to solve that core problem. And I think what is really important as a community is for us to be very clear-eyed about the problems that it solves and the problems that it doesn't solve. Because part of what we have seen unfold, and I think part of what's driving misinformation on a whole range of topics, is it's very easy to simplify problems. And it's very difficult to implement effective, complex solutions. And so a lot of what went wrong, I think, was there were some, maybe bad intentions. There was certainly, prioritizing domestic populations in the US and in other countries. But a lot of it is not having an operational plan in place and a way to move quickly in an emergency. So I think the questions, where we are no longer in the negotiations, largely or narrowly, us as individuals. But I think this question of coming to an agreement about exchanging data and samples in an emergency in exchange for a promise that countries will get access to medical countermeasures, there are some fundamental flaws to that being the core. And we could talk about that for hours, but I will just say one of those fundamental flaws is that access to pathogens and data is not the leverage point that many countries feel that it is or should be, because if we find ourselves in a COVID-type situation or a pandemic influenza, the samples and data are everywhere very quickly. So that is the core leverage point. It's not that strong of leverage, and we're not going to solve the problem with it. That's not to say this isn't a valuable exercise. It is a valuable exercise. We need agreement. But there is also a trade-off. We are now 5 years into these negotiations. It's been an incredible amount of resources in terms of time from the people in every government who have the most expertise on pandemic preparedness, resources, flying to Geneva, spending time in Geneva, and a lot of, political goodwill that I think has been burned in the process. So I think what we have to ask ourselves coming out of May, whatever the resolution is in May, is this the best use of everyone's collective time if we have a pandemic in 6 months? And I question whether it is, because there are a lot of solutions to solve. What I will just maybe more on the optimistic side to try to, where we have made progress. One of the reasons that there was a delay was a lack of access to financing to get in line with the manufacturers to purchase vaccines. There has been a lot of progress on the financing front in terms of new approaches to quickly mobilize access to financing for low and middle income countries and bulk procurement of medical countermeasures. That is kind of in the weeds and mundane, but it's hugely, hugely important in an emergency. And I think the leaders of many of these countries would say that. And maybe the last thing I'll leave off on is in the Mpox response, which, the 2024 Mpox response, where we had sort of another bite at the apple, Mpox-wise, but also outbreak-wise. I think we, from the US government perspective, did a much better job, but we were in a situation where there were highly effective vaccines that were in large supply in high-income countries for national security reasons, donations of over 4 million vaccines pretty much out of the gate, regulatory approval for those vaccines in high-income countries, and hundreds of millions of dollars available for the rollout. And we were still not able to get those vaccines into arms. So I think it just highlights, let's not fixate so much on step one that we miss step 2 through 100.
Here's my little push. Is there, so if the pandemic treaty is not going to get us there, is there a path to technology sharing globally, or is there just not one right now? Are we not in a world that can actually accomplish that?
So I don't think there's a simple path, but I think, part of what we were working on in the Biden administration was when you are, the US government has huge leverage when you're signing contracts with manufacturers at the outset. If you can build in conditions at the outset when you're signing those contracts for access and sharing of the technology, not just worldwide, but with the American people at an affordable price, that's where you have the leverage point. And even in the negotiations right now, we're talking about manufacturers opting in to agreements. The time you're going to get manufacturers to agree to conditions is when they're signing a contract to get a lot of money with high-income countries. So I think there should be more pressure there. But we also need to diversify manufacturing capacity and have a plan to build out and sustain manufacturing capacity around the world. And there are a lot of very promising individual efforts, but not really a shared vision or pathway to get there.
I'm tempted to ask two people very brief reflections before I want to move us to misinformation. You're one of them, and you're the other one. So, Nina, do you have a brief thought on the pandemic treaty? And Dr. Fauci, do you have a brief thought on conditioning scientific funding on access? So maybe Nina and then Dr. Fauci. Dr. Schwalbe and then Dr. Fauci.
Sorry. I was very involved in the pandemic treaty negotiations as well, but from the outside, not from the inside. I was not part of the U.S. delegation. I sat in the cafeteria trying to influence the U.S. delegation and every other delegation. And what we saw there was really overweighted pharma engagement. We could see who every delegation was meeting with, who they were having lunch with, and we saw the pharmaceutical industry pound its weight. So the big disappointment to me was that they won. And next week, there is sort of the final week of negotiation on the pathogen access and benefit sharing. And the lower income countries are going to get, I don't know if I can use this word, but they're not getting a fair deal. And that's that. And Europe just says that we're not in it. So we can't blame us at this point, but Europe just says no way. And that's the pharmaceutical industry. So I am a big proponent of conditionalities. And we spend, $50 billion a year funding medical research in this country, taxpayer money. And that should be a public good and a public benefit. So until we fix that as well, none of this is going to be fixed.
So I was not involved in the distribution, but the thing that struck me, who was looking at it purely from the scientific standpoint of developing a vaccine, that the idea of implementing real equity, either in the distribution of product that's already made or in the assistance to countries to be able to make their own product, is that it's a multi-step process. And just the willingness to share tens of millions of doses of vaccine is meaningless if there's no way of distributing them in the country that needs it. And I remember I was shocked once when, President Biden made the promise that he was going to put a lot of money into giving a substantial percentage of vaccines to countries in Africa, and they didn't want it. I'm not mistaken. They didn't want it. They said, we can't use it. We have no way of distributing it. So I think when we want to talk about long-range planning of the future, about how we can get implementation of equity, not just the concept of equity, it's got to be more than getting doses that you can give, but what happens when you have them to give? How are you going to get them distributed? I mean, that to me was very troublesome, that after all of the effort that the administration put in, to get a certain proportion of our doses ready to go, they weren't used.
No bites on conditioning funding with access. Thoughts? You can just look at me and say no matter.
No matter.
Nothing. Okay, thank you. All right. I want to move us on to another topic. I want to talk a little bit about misinformation. So, Jason, if you can kick off, one of the things that we saw very, very clearly in your book is misinformation rearing its head left, right, and center. I think a good third of the examples that you give somewhere in there comes with some examples of misinformation. So can you tell us what are your kind of best examples from the book and from your reporting, and what do you think we learned there?
Oh boy. I mean, there's so much to unpack, right? One of the things that I didn't appreciate until I spoke to people like Henry Masur and Deborah Birx, who had done a lot during the AIDS crisis, was that misinformation and conspiracy theories and things like that we were grappling with during the COVID-19 response have been around forever. Certainly during the AIDS crisis, but in history, you look back at the Milan plague of 1630, and there was misinformation and conspiracy theories going on then. So I think it's just part of the human condition that these things emerge when these sorts of existential threats emerge. So that was one thing. It's, some of them were just so bizarre that they were hard to comprehend. The one about Bill Gates and the silicon chip and the mRNA. Like, it was just, so much there. I'm waffling.
The only difference between hundreds of years ago was social media. I mean, that's the thing that really turned it around. I mean, misinformation and disinformation, as you said correctly, Jason, has been with us forever. But right now, you could say something absolutely preposterous. It'll get a click, and the more preposterous it is, the more clicks it gets. The more clicks it gets, the more money people make. And that's where we are right now. I mean, we're just being overwhelmed by the social media propagation of disinformation, which is, a real problem, which I don't see any easy solution to it.
Well, and I'm gonna follow up with you on that, Dr. Fauci, because there's I think, and I think you are both somebody that we turn to when we think about science, but you're also somebody that we turn to when we think about public health, right? And messaging in simple ways. I have a hypothesis, which is that public health is really quite good when we don't have an active enemy, right? We're pretty good at messaging when we have to get the messages out there about kind of things that people don't know about with real information. But when there's somebody that's actively trying to do the opposite, right? When we have an opponent, then all of a sudden the tools we have don't work as well. And so you're obviously somebody that's dealt with, I mean, I know no one that's dealt with more misinformation than you have of late. Some of it from lawmakers, some of it from the media, some of it from others. Do you think that there's, what are we missing, and what do we need to kind of figure out in order to get to a place where we can actually tackle this misinformation?
Matt, I don't have what I'm confident is an answer that's the solution, but I can give you an observation that when we talk in the public health community, we talk on evidence-based things, that this is true. It was published in Nature. It was published in New England Journal, that has a method section. It has the statistical analysis, and it has 17 supplemental figures. Okay. People don't relate to that. They relate to someone who is an influencer who will say, ivermectin, it worked for me. That completely overcomes any 20,000 person study that proved that ivermectin doesn't work. It's stunning, it's painful, but it's true that just somebody on social media who's a trusted influencer will outflank any scientist who's trying to show you data. So you can't fight misinformation with data. You have to fight misinformation with figuring out a better way to communicate to people on a level that they understand that's really simple. We'll lose that battle all the time.
Nina, I'm going to come to you on this. I think there's a really, so the Center for Global Health Policy and Politics, what we don't do is we're not epidemiologists. That's not what we're thinking about. But what we are thinking about a lot is these questions of how do we build political capacity to respond to kind of crises like pandemics. In your book, Jason, there's an amazing stat that I will, now that I've moved past Dr. Fauci, I get to read it, which is Cornell University found in an analysis that that President Trump was the single largest source of COVID misinformation in 38 million news articles. 38 million news articles. So that's pretty remarkable, right? That is the kind of torrent.
Beats the New England Journal.
Right? And so you think a lot about politics. You think a lot about public health in those things. So do you have thoughts about kind of where we need to go and what kind of capacity we need to be building?
Yeah, the first thing I've thought about a lot, and I was in a wonderful discussion in Montreal a couple of weeks ago with the new pandemic center. They've just opened, and they were able to speak really honestly about the pandemic and what they'd learned and what mistakes they'd made. And I've thought a lot that we need to do a truth and reconciliation process here around that, like they did in South Africa in the post-apartheid period. We need to be able to first sit among each other and talk about, yeah, I told people to put on bandanas. No, I always thought the bandana wouldn't work. So just to talk about the basic science. And what I love again about Jason's book is I learned a lot of things. There's uncertainty. There's still uncertainty. So I think we need a formal process. The UK has done a formal review. I understand the state of Louisiana has done a formal review, but we haven't done it as a nation. So that's really important. And if our government isn't going to lead us on it, maybe Georgetown will. So that's the first thing. The second thing I think we need to do is then take a look back at the science, because we had so much science that we didn't learn from. I mean, we still don't know, like, if 3 feet or 6 feet or 4.5 feet or 1 foot. And we had so many experiments and so much data that we didn't take a look at. And what I was always struck with the mask data, and this may be myth, but it was like, oh yeah, that worked for flu. That's why we did that initial 6 week or 6 feet. And like, don't we have better information now? So really to take a look at that, what is the best practice on testing? I mean, in New York, we were doing individual testing. What I learned in school was like, we should be doing population-based samples, but that's not what we were doing. So looking back at all of these things, particularly with the non-pharmaceutical interventions. And the third thing that I think we need to get much better at doing is communicating uncertainty. We're really bad at communicating uncertainty, and I think people can handle it because the world is an uncertain place. And I'll close this thought by saying I was talking to this weather guy the other day who used to be a reporter for the Washington Post and has written a lot on weather. And he's like, yeah, we say 30% chance of rain. And like, that's okay. Everybody knows it could be 45, it could be 10. And I thought we really have to get better. We don't know everything, and there is uncertainty in our work. And we have to think about how to explain that because we say things too simply, and then we lose the trust.
All right, in just a few moments, I'm going to open it up to this crew, but I would like to kind of first, I have one more question for each of you briefly. And what I want to do is I want to turn from what's wrong to what do we do about it a little bit more. And so I'm going to start with you, Stephanie, and this question of what do we do in the US right now? And talk a little bit, I know you're doing some domestic work. I know we're thinking about kind of what states can do, what localities can do. One of the realities that from where I sit that I see is that the federal government is not going to play the role that is needed in the next pandemic. And so we are watching states step up and do things like joining the WHO outbreak networks and doing a variety of other things. So from that perspective, what do you see as the to-dos?
Yeah, I mean, I think that the modeling, which probably people in this room know, the modeling says that there's about a 50-50 chance of another pandemic, at least as bad as COVID, in the next 25 years. So that could be in 4 weeks, that could be in 25 years. We don't know, but it certainly is not an option for leaders, for state leaders and for others to just be frustrated by the federal government and hope the pandemic doesn't come for 3+ years. So as you are kind of alluding to, there's this Governor's Public Health Alliance that I think has 15 participants now that I think the leaders of these states are just acknowledging on day one, they're going to be the ones responsible that are standing in front of their state populations, explaining what's happening, what's the plan, how are we going to fix it. So they're putting some plans in place. I think the basics, which we all know of what needs to be done, are doable. So we need to prevent new threats from emerging. So, for example, bird flu, which I think is a real threat of a future pandemic. And there is much more that needs to be done in terms of making sure that those threats don't emerge. Biosafety on farms, guidance to farmers, testing in communities. But we also need to have better biosurveillance systems in place. We need to be able to quickly detect threats when they emerge, even if it's a novel threat, be able to respond quickly, identify the threat, give clear, quick guidance to clinicians about what the threat is and how to identify it. And then we need to have a plan to respond with, whether that's masks, distancing, hopefully not shutting down schools. What are the options based on what we learned in COVID for actually responding? Every threat will not be COVID. We could have a threat emerge that has 5-10% fatality. And that is a very different situation, even in terms of people who are skeptical about vaccines, if you see that many people around you dying. So the 3 steps: stop a threat from emerging, identify the threat quickly, contain the threat, have a way to respond to the threat, and keep people alive and keep hospitals from getting overwhelmed. We all know that those are the steps. And I think the question is, what can states do to make that happen? When you have an alliance of 15 states, including states as big as California, there is a potential to form partnerships with WHO, with private sector partners to think about, and with governments in other countries to think about how you would procure countermeasures in an emergency. And that is, I think, what they're doing and what needs to be done. And then, each of us, I think, needs to continue to put pressure on elected leaders to make it clear that we are worried about our public health systems. We are worried that we're not ready for an emergency. And we want to know what the plan is, both in terms of money, resources, and staff to respond if an emergency arises.
Nina, I'm coming to you next for building off of what Stephanie just said. And what's your top thing that you would try to name in terms of forward looking? If you were, for example, elected to office, what would be your number one thing that you might do?
If for example, I don't want to give up pressure on our federal government. States can do a lot, but it's not, we have to work together. That's the nature of public health. One thing that I think was a missing opportunity in COVID was building our primary healthcare system. We are the sickest people in the world. Diabetes, obesity, you name it. And healthier people survive better when they're hit with threats. So that is a number one. The second thing around this plan is all of society. I think we're still thinking of it as an epidemiological response or a public health response, and we need to think about schools and nutrition programs and how we get harm reduction services to people who are not reaching. So this all of society response, which is good public health. That's good public health. And then finally, I would like to see a truth and reconciliation process so that we can acknowledge our mistakes, have grown-up conversations, and move forward.
Jason, your question is a little bit...
No, please keep me with that question because
It's your question. Go. I take back the question I was going to ask you.
All right, sure, because I've been thinking about this one. So one of the things that emerged very clearly with COVID-19 was that when a novel virus emerges causing a new disease, unfortunately, it doesn't cause just acute illness, but we see chronic illness. We see this infection-associated chronic illness. I think that it's always been in our past, but we've recognized it much more clearly now. Like, Ebola, polio, many of these things have come with sequelae, and we definitely saw that. So we need to do a better job at tracking it, identifying it, treating it, and preventing it for sure. So I'd like to see much more investment in that.
That was literally going to be a question. Well done. Dr.
Right.
Fauci, the last kind of piece of this. Part of, you can also, like Jason, answer whatever question you'd like. You can always do that. I'd be particularly interested, though, in one of the things that Jason kind of includes in his book, which is about kind of the patient-facing patient advocacy that happened. And I wonder if part of what we have not done well is to learn those lessons now of at least two pandemics of, of how we think about responding to people that are facing illness. And you have certainly done that in the HIV crisis in a way that very few people in the world have. And I'm not sure that we ever achieved that level when it came to COVID and long COVID, et cetera. So do you have reflections there?
Yeah, I mean, COVID is obviously a very different disease than HIV, but what I learned personally, and what the field learned was the importance of getting the perspective of the involved community. And in the case with HIV, it was predominantly, not exclusively, but predominantly the gay population, mostly young to middle-aged gay men, which were involved in the entire phenomenon of the HIV outbreak. What we learned from them about the design of clinical trials, about the user friendliness or not of clinical trials, about the rigidity of the regulatory process, I think transformed completely the way we were able to respond successfully to HIV. So again, with recognition of the differences between COVID and HIV, I think the fundamental principle of heavy input from the people who are involved, the people who are at risk, might actually be a real step forward in understanding that. I just want to make one comment what was said about a reconciliation. If we were a different country, I think a reconciliation would be fine. But I don't think right now, today, that we can have a bipartisan approach to anything. I mean, take a look at some of the congressional hearings that we've been having on, it's just, enough said, is that we do need a reconciliation process if you have people of goodwill on both sides trying to reconcile. But I'm not so sure we have that right now in this country. Sorry.
I think we can start with our own universities, because I think we had disagreements that we have never. I mean, we have people who are pro-mask and anti-mask. We have that. And they're all, or people who are pro-school and anti-school. And the data and science evolved and were unclear. So I think we can start with really honest conversations. And that's what I love about the South Africa process is they figured out how to have an incredibly complicated conversation by starting with real people.
Right. I totally agree with you on what you said. I think if we can do it, perhaps at the university level, even having universities of different ideologies where you respect the ideology of the other and you don't consider them an enemy. But right now, the divisiveness in our country is going to make it very difficult to do that. So it would have to be at another level other than the political level.
Well, and I will just conclude here by saying that I think part of what I really like about this conversation as we move forward is that we have got to figure out what are the solutions for our current political context, right? Just saying like, I hope at some point our political context will be better and then we can welcome the next pandemic. I worry that that's roughly our strategy right now, right? And so to this particular thing, we have to be able to operate in this political environment and recognize what's not working. So to your point, that we're way too often operating as if we have bipartisan agreement, as if we have kind of functional structures there. And so if we don't, within the public health world, figure out some sort of alternative that doesn't rely on bipartisan agreement, which in Washington is the way in which things have operated, we can't afford to wait until we get to a place where we're in a different situation bipartisanly. That's just not going to work. So anyway, with that lovely thought in mind, so positive and forward-looking, we hereby open it to you all. And so if you may, my colleague who is somewhere right there, Colleen has the microphone. She will come around. You can raise your hand and we will call on you. Go ahead, right over there first. And if you can, keep things relatively short. We can hear from a bunch of people. And what I'm going to do is I'm going to take a few, and then we'll see who wants to respond from the panel. So go ahead.
Great, thanks. I'll be short. My name is David Walton. It's great to see you all. Thanks for hosting and thanks for being here. I have a bit of a tactical question. It sounds like, and of course you all are the experts, that we have a good understanding of what needs to happen in terms of the next pandemic, reality notwithstanding around the difficulties. I want to get back to the disinformation bit, and particularly, at least through my experience in malaria, even before this current administration, we, as the new malaria vaccine was being, we were actively working to get it out into countries. There was deep early misinformation. Some of them was state sponsored, but a lot of it wasn't. And so I wonder, as you all think about the next pandemic, how the sort of offense for information can be really thought through. Because again, as a medical provider, we sort of present the evidence. We're an evidence-based group, and we say, this is what the data shows. Here you go. And that just isn't working, and it hasn't worked. And so, increasingly so. And so I just wonder how you all would think about what that anti-disinformation, that's not a great term, approach would look like.
Great. Thanks. We'll take a few. So in the back corner.
Thank you so much, Asia Russell from Health Gap. I guess from my perspective, bringing us back to the global access questions that came up, and that, I was in Uganda when the first outbreak happened and saw a lot of clinicians die without oxygen. Charles Chigundu, an incredible OBGYN who was like fighting maternal mortality in the country day and night and had trained everyone in the country to save women's lives, to perform abortion, to do everything that was necessary. And he died with a pulse ox of it was like almost, you couldn't detect it. And he couldn't get a bed at his own friggin' hospital. And he collapsed. And no one could even really talk about it. So I'm with you, Dr. Fauci, in that it's like vaccines are the tip of the spear, but the inability to contend with the depraved hoarding, not just from the US, but from, the EU texting the head of Pfizer and boasting at getting so many doses that then she couldn't even turn around and use. That tells us something about everything else. The health workers, how are you going to deal with actually getting the commodities out to people? So it's not that the vaccines then don't matter. But of course, when, negotiators in Zimbabwe were being told basically that they had to pay more, even than the price being paid by EU member states, it matters. While their people are dying, their frontline health workers were dying, while there were, funeral pyres in India, as we all remember. And that was what compelled the US. It's like, this is not a criticism in a way. It was also in moments of political crisis, what sharpens the hand of the policymaker is the crisis itself. And I guess my question is, we struggle because we don't want to have to recreate the crisis in order to get the big swing. I think now we have an administration that craves inequity, even the inequity and chaos that come from outbreaks. And what we need is the stabilizing force of policies that actually anticipate and then crush that inequity through what the risks they're willing to take. And I think we were dismayed during the Biden administration that those big swings didn't seem to be there. There was too much hesitation and a lack of understanding that actually the momentum can be at your back to push industry to do what it doesn't want to do on its own, because you get the forgiveness, the kind of blurry, beautiful light of the pandemic. So how do we anticipate that now and get the commitment from duty bearers that will hopefully escort in a next administration that's sane about these issues, to say now, yes, we will take the big swings. We will challenge, we will use the Defense Production Act, not just for ourselves, but for others. We will take these kinds of approaches because we will be in that moment again. And I think we don't have to have that amnesia that sometimes mainstream politicians have. So not really a question, but a gripe. And also a call to action, because we have that power, and it's really the people, when Dr. Daskalakis had the glow of being able to resolve Mpox, he used that for other issues as a communicator and as an activist. And we just need more of that.
All right, one more. 8 million hands. Okay, right on the end there. I can't even see your face. So whoever you are.
Hi, thank you. I'm Carmen Pan. I'm a health reporter at Politico.
So I wanted the current head of the NIH has argued that the way you prepare for the next pandemic is making Americans healthier overall, trying to solve the chronic diseases or, improve the situation here. But, if the next pandemic hits anytime soon, how do you expect people will react when sort of like every day they're being told from the top that their healthcare system is meant to keep them sick, that, nobody, no government, no health official should ever tell them what to put or not to put in their bodies? Like, how do you deal with that sort of like, mistrust, distrust, uncertainty that people are being fed, and that, in so many ways, it's also backlash to some of the COVID response that we saw here in the US. And we see that in other countries too, but specifically for the United States. Thank you.
All right, I'm going to turn back to you all with these three complicated questions. So the three are a tactical question on kind of misinformation and kind of what do we do there? A big picture question on what does it look like to kind of build a politics now that might be able to take bigger swings in the future to achieve, and can we do that? And then a question about kind of like, where are we on this current context in which information from the state is being given that you shouldn't trust healthcare. So do you want to go this way or that way?
So you make a very good point, and I believe, and others have spoken about this better than I have, that when you're anticipating disinformation, that you could almost pre-bunk it, in essence, getting out and attacking the anticipated disinformation before it even occurs. And you have to be really aggressive, because once disinformation gets out there, it's, as you well know, it spreads very, very, very quickly. And it's almost stating things that are counter to the misinformation as opposed to responding to the misinformation and the disinformation. I think that's the only way to go. Otherwise, you're always playing catch up. And when you're playing catch up, you're losing. Right?
Jason?
The only thing I would add is what Tom Bollocky from the Council on Foreign Relations and Sylvie Briand from the WHO have told me, is that we have to assume as we go into the next pandemic that we'll be operating in a low trust environment. And I don't know that we can count on political leadership to be, pulling in the same direction necessarily as public health. So I think it's a new reality that we're having to reckon with.
Great, thank you. I think that the Biden administration didn't do a good enough job when it had the chance of negotiating with pharma. And certainly when we were at USAID and trying to negotiate some access provisions, we just couldn't make it up the chain. There wasn't the political will to really strong arm. So that's something I think we need to keep pushing on. I think a big part of trust, particularly in the United States, is that people spend 6 minutes with their primary healthcare providers, who are basically on Epic like the whole time. And the answer to that is not AI to take notes for the provider. So I think that's really rebuilding this, because that's where we all know as scientists that that's where people get their information. They get it from their nurses, they get it from their doctors, they get it from their neighbors, a lot of whom are nurses and doctors and primary healthcare providers. So we have to increase. That's how we increase trust in the system, is just let's let the providers do the jobs that they were trained for 8 years, 12 years, and stay with patients.
Well, so I will weigh in mostly on the international side, but I'll just say domestically, I think it's really important to keep in mind that normal people are not political leaders, and political leaders are not normal people. So,
The latter being the most obvious.
Well,
Yes.
So most families want to keep their family members safe. And the way that people are making decisions varies. And people clearly are often making decisions that are counter to their own health. But that's not the same as, what we're hearing, I think, from some of the political leaders who, in some cases, are benefiting financially from advancing mis and disinformation. So I think, having a little more space for hope and trust in just normal people in a crisis, wanting to get the right information, finding ways to do that for people, and, navigating some of the confusion, assuming that people have good intention, which, most people do. not all, but most. On the international side and just the question of big swings, I mean, I think this is a fair point. I think that we need to be thinking about big swings across the board. Particularly, I was a political appointee in the Biden administration. I think if there's another Democratic administration, the swings need to be bigger. And part of the conversation that needs to happen even before then, and I think during an administration, is again assuming good intent on both sides and working through some of the challenges of doing that. So I will disagree about the role of pharmaceutical companies in the U.S. government's position in the pandemic accord negotiations. That just was not what was driving our positions. But I will say that, when political leaders are very, very focused on lowering the prices of drugs for Americans, there's only so many things that you can negotiate with the parties on the other side of the table. So I think understanding the complexities when people have good intentions and have interests that are aligned with yours, and sitting down together and working through how do we get to where we all want to be, and maybe we'll try 15 things and only 2 of them will work. It does, Asia, strike me listening to you talk about this. Maybe we can push countries right now to make a commitment to share countermeasures for health workers in any health emergency. That is a more narrowly defined, easier to do thing. And it is absolutely something that we should be doing, not instead of the pandemic treaty, but in addition, if it goes off the rails in parallel, what can we bite off that will actually save lives if we find ourselves in an emergency in 6 months? And I think the example you're giving is so striking and was so devastating, as Jason wrote about in his book, for health workers in the US and health workers around the world.
Does anybody have any kind of insights about next pandemic hits and we've got active misinformation, or at least active encouragement of distrust coming from the current government? Thoughts?
Well, I am all for wellness, and I think wellness is really a good thing. And I know that our country, because we're sicker than other countries, tend to do more poorly during pandemics, which we have done. We have more obesity, more heart disease, more diabetes. But wellness alone is not adequate preparation for a pandemic.
That is a quote that if were this not closed to quotes, I would say it was a good quote, but we'll see. We'll go public later. All right. Did you want to say something, Vic?
I mean, I'm not sure if that was kind of reflecting on something that I said, but it's about these community health centers and about trust, and people have nowhere to go for their health or their health information. And I think what we saw is a total breakdown of trust. And I live in a city where people really can't get access to healthcare. So who do they trust? They go to Truth Social or whatever, where they get their information. So for me, that primary healthcare is about making people healthier. And it's also about having access to medical providers that people can trust. And I think, where would I go? I mean, based on Jason's book, I'm going to New Zealand.
I think there's one more person who gets to ask a question. All right, you win. 2 more people. We'll get, because one of them is you guys over here. And then we're gonna move toward close.
Fascinating panel. Thanks for your time. My name is Matt Brown. I was the NIH representative in China during the COVID pandemic. In the early days, there was a lot of misinformation. There were missteps, I think, between the diplomatic corps and as a scientist based in a U.S. embassy. There wasn't diplomats didn't really speak the language of science, and the science really wasn't able to, our domestic focused agencies such as NIH, FDA, CDC had difficulty working through the kind of diplomatic channels that are established. Our diplomatic notes went unanswered often. It was difficult to get timely responses in a coordinated way. My question is more tactical. Like, what can we do to encourage a stronger workforce on these front lines of diplomacy and public health that can be more prepared for the next pandemic? Is this the domain of academia? Is it the agencies themselves have to be, especially the domestic focused health agencies, more more engaged and intentional about working internationally and through our mechanisms? Is it more trade, pharmaceutical, civil society that needs to have stronger communication ties that can help complement? During times of crisis, we saw how difficult those communications were among nations in a timely way. Thanks.
Anmol, last question.
Thank you, everyone. This was a great panel, very insightful. I have a very simple question. So during the early chatter through the COVID-19 pandemic and also the pandemics before that, a lot of focus in terms of what global health security and pandemic preparedness should look like has been towards multilateralism. And after emerging from this pandemic, what we now see is even more fragmented than it was before. So how do you say that we, as in response from the United States or also on a global level, how do we make it move towards that, or if that move is essential in the first place? Thank you.
Anmol is a fantastic, amazing fellow at the Center for Global Health Policy and Politics, and definitely does not ask simple questions, even when she says she is. All right. Closing thoughts. Following on Matt's question around kind of global communication and ties, following on Anmol's around multilateralism, I didn't get to ask my question about WHO that I was going to put Stephanie on the seat for, so that has to be a different panel, and we'll do that one. But if you all kind of have some quick reactions to those two big questions, that would be really welcome, and then we're going to turn it to Rebecca to bring us home.
Well, multilateralism is obviously very important. Global health is a global issue. And I think if we shrink away from our interaction globally with our partners, it's going to be to our own detriment, for sure. I mean, that's not, such an insightful statement. It's an obvious statement. So that's the thing that's troublesome when everything we're talking about now is pandemic preparedness. Pandemic preparedness is not just a domestic thing. It's interaction with our international partners. And that's something that, unfortunately, we seem to be steering away from right now, which is very troublesome to me.
Sadly, I don't have any wisdom, but I think of when I interviewed Helen Clark, a former Prime Minister of New Zealand, who was involved in assessing the response to the pandemic for the World Health Organization. And she reminded me that during the global financial crisis, the G7 came together and came up with great solutions, and there was leadership there. But during COVID, there wasn't. We were sorely lacking in global leadership, and we paid the consequences.
My first recommendation is to read Jason's book because it has a lot of insights. And I just think we have to do better. I was really struck by the snowstorm a couple of weeks ago. And I went to Trader Joe's and there was like no food. And I thought, oh my gosh, can you imagine if this was another pandemic? This is just a snowstorm. So I think we just have to, what I love about Jason's book again is that everybody in this room was involved, and it allows you to reflect on your thoughts and challenge your thoughts based on a beautifully collected science and evidence-based read.
So Matt, first of all, thank you for the work that you did. I'm sure that was an incredibly difficult job to have in that moment. I think that this speaks to the importance of having people with expertise working across the different agencies that are working at the embassy or in countries together. And a lot of that capacity, as many of us know, has been destroyed with getting rid of USAID, cutting back CDC's global presence, NIH presence around the world, FDA presence around the world is so critical to keep our medical products and food safe here. It's not sufficient. I mean, State Department diplomats can do a lot of things and are excellent at their jobs, but they are not all of those agencies. And it's very difficult to do it effectively without that capacity. So I think that's one of the ways where we will be much less prepared in the next pandemic. On multilateralism, and I will touch on WHO. I think WHO is an absolutely essential institution. It's a huge mistake for the United States to withdraw from WHO. Just for perspective, The assessed contributions annually that the US government should be paying to WHO is about $130 million, which is the equivalent of the budget for ribeye steaks at DoD right now. So to suggest that this is a financial or budgetary decision is nonsense. That is not what's happening, and it is a worthwhile investment for the American people. It's an imperfect institution. There's a lot of work that needs to be done to make it stronger, but it makes us less safe to be withdrawing from WHO.
All right, good. All right. So thank you very much, and just thank you on behalf of the Center for Global Health Policy and Politics, the Georgetown Global Health Initiative, and the Center for Global Health Science and Security. With that, I'm going to turn it over to Professor Rebecca Katz, who is the director of the Center for Global Health Science and Security, who because we're at an academic institution, we asked somebody to be the discussant, and we gave Rebecca the terrible job of closing this deep, rich conversation with her reflections. So please, Rebecca, over to you.
Thanks. I'm also cognizant that it's 4:28. So
sorry for the 2 minutes.
I'm gonna skip.
You can have 4. It's ever okay. Nobody's in a hurry.
I'm gonna skip my second page of deep thoughts, but I listen, I'm really delighted that this conversation is happening and to be here and be part of it. And think of it a bit as a continuation of a discussion, right? Dr. Fauci's been having these conversations for decades. And in fact, actually, it was January 2019 that Dr. Fauci was the keynote at an event that we held on campus on what was it called? The Pandemic Preparedness for the Next Administration. And planned, it was an event that it was planned by me and Ashish Jha. So it was joint when he was still at Harvard. And it was planned before the election. So it's an interesting event. But again, these conversations have been going on for a while. And I told Jason this, but we've been having a conversation for many years as well. And I went back and I think the first one we had was at the Global Health Security Conference in Sydney in June of 2019. And with apologies to UIS, I don't delete my emails. And when I went back this weekend to figure out, just to look at that history, I had 915 emails from Jason. But serving a really important role of collating information and pushing it out, and one of the many important sources of information that we all had in the stories that were coming around from around the world. And I think, so I'm thankful for the book, but I'm also very thankful for those daily emails. I think we are still learning, what are the results of the pandemic? What does this mean? 6 years out, we didn't talk a lot about educational loss, but there's a lot that we are learning and how that might influence the different types of decisions that might be made. We also, I don't feel comfortable saying that we know the exact number of morbidity and mortality, the exact cost to the global economy, what really happens with mis and disinformation, and how do we address it. And, maybe instead of relying on New England Journal of Medicine articles, we, as a community, we start thinking about marketing in the ways that there are some very sophisticated tools out there on getting people to do what you want them to do, but, for drinking the type of soda they want, as opposed to what type of actions might save their lives. I think we also, and to Jason pointed out in this book, there's a lot that we don't really understand on long COVID, on the experience of infectious to chronic and what that means to take care of people and their lived experience, to the future of mRNA research, and research in R&D in general. I think I saw Mark from CEPI walk in here. And how does all of that translate into this idea of a 100-day mission, and how does that get operationalized? And I think, to the points that were discussed, how do we, people use the word implementing, I tend to use operationalize equity, and operationalizing collaboration. I don't know if that's the right way to talk about it, though. And addressing the realities of the situations that we're currently in, and what that looks like going forward, from the relationship between governments and the relationship of governments to their communities. And we didn't really talk a lot about that, but been fortunate to be part of, as you know, Stephanie mentioned, some of the work that's happening at the state level. Last weekend was involved in conversations sponsored by California Department of Public Health on trying to codify some of the relationships with CBOs that existed, that stood up and then rapidly stood down. So, you know, we're living in an environment right now where there's a lot of unevenness. There are countries around the world that went through the COVID experience and said, wow, we're going to double down, and whether, you know, some have resources, some have don't, but they're building really innovative solutions and collaborations and information sharing and response networks. We are in a country right now that went through the same experience and then decided to dismantle a bunch of our institutions that deal with this. So I think there's a lot of, think of the positive. There's a lot of opportunity right now to be innovative in our thinking about who the stakeholders are right now, what is the current role of government, what is a potential future role of government, how do we think about the role of the private sector, of non-governmental entities, in civil society in general and academia, and then also how do we train our students to be part of that future environment when we're not 100% sure what that looks like, without sending them all to Anthropic. Or maybe that's the solution, right? And then that's what you do in the short term, and then you come back when public health is funded again. So I will say that I think there's a lot of really interesting things that are happening right now. It's been a fascinating discussion. The takeaway is to buy the book, that we should put it on our syllabi. And we'll add it to Dr. Fauci's book on the syllabi. I think I saw Emily in here. Well, we have a whole bunch of books we can then start assigning. But I'm just really, again, delighted that we're having these conversations and that they are part of our discourse. So I'll end there.
Thank you, Rebecca. And thank you to our amazing panel. Please give them a round of applause. And please do go ahead and sign up for updates, other things from Georgetown. We hope that you will kind of continue to engage with us as time goes by. And thank you all for being here. And most importantly, hopefully this is a conversation that then kicks off, as Rebecca says, the next phases of these continuing, ongoing conversations, because I wish we were where we were in 2019 in some ways, right? And so we've got to figure out how to do this in the environment we have. So thank you all.